Yes, Ms. Pottle.
Sir, this morning, our first witness is paramedic Fred Thompson. May the witness be sworn.
Please.
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. You may sit down.
Mr. Thompson, thank you very much. Do sit down, or you can stand if you like. Most people find it easier to sit down. Just give me a moment. Could you just find me a pad of paper, please? Yes, Ms. Pottle.
Hello, my name is Emily Pottle, and I'm asking questions on behalf of the inquiry. Can you state your full name, please?
It's Frederick Adam Thompson.
Mr. Thompson, you've provided a statement to the inquiry in this case. The reference is 005142. If that could be brought up now, please. Do you recognize that document?
I do.
Okay. Can we turn to the last page of the statement, please? Yes, and we can see that the statement was taken by an officer at SO 15, and the officer read it back to you, and you signed it. Have you had a chance to review the statement before giving evidence today?
I have.
And is the statement true to the best of your knowledge and belief?
It is.
Sir, with your leave, may that statement stand as the, may it be adduced into evidence?
Yes, certainly.
I'm grateful. Mr. Thompson, first I'd like to ask you a bit about your qualifications and your role in the medical treatment of Miss Sturgess. At the time, and that's June 2018, you were employed by the Southwest Ambulance Service Foundation Trust as a HEMS paramedic, is that right?
Yes. Yes.
At that time, you had been a paramedic for 18 years, is that correct?
That's correct.
Mm-hmm.
Yesterday, we heard evidence from paramedic Keith Coomer, who is an advanced technician. Can you explain to us what training a HEMS paramedic undergoes?
The HEMS paramedic are recruited from the paramedic profession, and to be a HEMS paramedic, you have an extended skill set of physical skills as well as pharmacological extension for extended drug use. And you also undertake an in-house training program which is directed to critical care paramedic practice based on the pre-hospital emergency medicine syllabus, which is endorsed by the Royal College of Emergency Medicine and the College of Surgeons.
I see. So it's further training than if I can put it this way, a regular paramedic would have.
It is.
Okay. And we've heard also in the evidence about critical care paramedics. Is that the next stage up, if I can put it that way?
You progress to a critical care paramedic after completion of the HEMS paramedic training.
I see.
An extended portfolio with being supervised for up to 2 years to completion of it, and accumulation of the FEM course, which is a pre-hospital emergency medicine course, for those working in our ambulances is a requirement to undertake.
Okay, but you were not at that stage a critical care paramedic, you were a HEMS paramedic.
Looking at my statement, I believe I signed it as a critical care paramedic, so I believe I was a critical care paramedic at the time.
I see. If we can just take the statement, if we can just bring it up, 5142. And in fact, you have it there in front of you, don't you, Mr. Thompson? I think it says occupation HEMS paramedic there. Do you see that?
Yes, ma'am, I do.
Okay. So do you think you were HEMS paramedic at the time?
2018, I qualified as a critical care paramedic, and I refer to Nick Wilson's document, who's the SWAS officer, who's actually unnoted his evidence as a critical care paramedic.
Okay, okay. So that's a mistake, I see. I'd like to ask you now a bit about the training and guidance that you received on organophosphate poisoning before we turn to the events in question. Yesterday, we heard evidence from Wayne Darch, and he explained that a clinical notice regarding duodote auto-injectors had been emailed to all paramedics prior to the poisoning of the Skripals in March of 2018. And that clinical notice asks clinicians to familiarize themselves with the duodote medicines protocol, which, if we can bring up now, is inquiry reference 000623. Mr. Thompson, do you recognize that document?
I don't recognize the document.
Do you recall receiving information about the duodote auto-injector prior to attending Dawn Sturgess in June?
Obviously, it's a long time back.
Of course.
When I said I don't recognize the document, it's probably because over time I can't recall the document. However, we did have training as a SWAS organisation, provided us training on our annual development days, and we were also given a clinical notice from our line managers, which is called operation officers, on the duodote injection.
So do you remember receiving some information, if I can put it more broadly, from your line managers about the duodote auto-injector?
I can remember receiving some information with regards to it of the instruction. It was left open for us to familiarise ourselves with over a period of time, but that's all I can recall. It's a long time back.
It is quite a long time ago now. Can I ask you whether then you were familiar with the signs and symptoms of nerve agent poisoning prior to attending Dawn Sturgess in June 2018?
Specifically nerve agent poisoning, I can't recall specific training on
I'm sorry, say that slowly for us, please, Mr.
Sorry, sir.
Thompson. It's all right, but it's my fault I'm not hearing.
I can't recall specific nerve agent poisoning training, but
No.
I can recall is the organic phosphate training as part of the duodote.
I
Right.
see. Well, we can see, in fact, from the medicine's protocol that that medicine is for organophosphate or nerve agent poisoning. And so the clinical symptoms would be the same for use of the auto-injector. If I can just ask that we look at page 5 of this document that's up on our screens. So this is the final page, and it sets out in an easy-to-read format, I think, information on when to use the auto-injector. And if we just zoom in on the 2 grids at the bottom, we have the signs and symptoms of nerve agent and organophosphate poisoning, and then a reminder of the step 1, 2, 3 plus. Under signs and symptoms, we have recorded chest tightness, wheezing, respiratory arrest, bradycardia for circulation, pinpoint pupils, meiosis, seizures and unconsciousness, sweating, fasciculations, paralysis. Can you help us with what fasciculations are?
No, ma'am. Mental block.
Can you help us? Paralysis would be not being able to move. Is that right?
Correct.
Right, okay. And then under the other symptoms, we have nausea, vomiting, fecal and urinary incontinence. So these are the signs and symptoms of nerve agent and organophosphate poisoning. Would you say that you were familiar with these signs and symptoms before you treated Don Sturgess?
For some of them, yes. For all of them, no.
Okay.
Well, I'm not quite sure, Mr. Thompson, whether you're being asked whether you were familiar with them because you'd encountered them at work, or whether you were familiar with them because you'd seen the training material, and they may not be the same thing. So, which was it? Or was it both?
From a training perspective and a learning and informative perspective, yes, we were aware of the steps 1, 2, 3
Right.
of organic phosphate poisoning.
Yep. And this, with this list of likely symptoms or not?
Yes,
Yep.
Okay.
Had you actually ever encountered a nerve agent case
never,
or an organophosphate case?
never,
Did you know anybody else who had?
no.
No. Right.
Before I move on from the training that you received, we also heard yesterday from Mr. Darch that after the poisoning in March of the Skripals, there was emailed to all staff a document prepared by NHS, PHE and NHS England on a reminder for emergency departments on the treatment for organophosphate and nerve agent poisoning. That document is 000659. If we could bring that up, please. Do you recall receiving this document?
No, ma'am.
No. Well, we needn't take much time with it, but it sets out also clinical guidance for nerve agent poisoning and a summary of the symptoms you might expect in a case of acute poisoning. But if you don't remember receiving it, then we...
Do you know whether you had it or not, or are you simply not remembering?
I don't recall seeing it or having it, sir.
Right.
Okay. Can I ask, as a HEMS paramedic, you were still employed by the Southwest Ambulance Service Foundation Trust. That's right, isn't it?
That's correct.
Okay. So if emails had been sent round by Wayne Darch to all staff members, we would expect that they would go to you as well?
If to all staff members, yes, ma'am.
Yes, okay. Now I'm going to ask you about the events of the 30th of June. And here we can refer to your statement, which you can have in front of you. So on the 30th of June, you were on duty and you were call sign CC23, is that right?
Yes, ma'am.
Okay. And you were monitoring a Category 1 call, as I understand it, which was the call regarding Miss Sturgess. We heard evidence from Mr. Coomber yesterday that he had requested HEMS. Do you remember whether you were requested to attend or in fact you were monitoring the call and had decided to attend anyway?
For my statement and my recollection, I can remember following the call through the process, and I believe it was my crewmate on the day that actually contacted the HEMS desk to say that we will respond to this call and for them to allocate us to the call.
I see. So you were monitoring the information about the call, and we'll come to that in a moment, and decided that you would attend. We have the call log. In fact, we have it in the expert's report, and that is document 5942 page 37, if that could be brought up. This is, it should be on your screen. It's a distillation, if I can put it that way, of the call log prepared by the expert. It's just a little bit easier to follow.
You see what it is, Mr. Thompson? It's someone's extracted these entries from the call log.
Yes. And so we can see that the call was received at 10:14, and it was given a category 1 at the same time, in fact, noted as fitting. We can see that at 10:16, the rapid response vehicle, that was Mr. Marriott, Mark Marriott, was allocated at 10:16, and at the same time, the ambulance call sign 312, which was Mr. Coomer, was allocated at the same time. And then we can see at 10:20, notes were added, patient has taken drugs and having a reaction. Do you remember seeing that on the log? Is that information that you would have had?
It's information that would have been on this system, not necessarily. I can't recall seeing it when I looked at the log on the day.
I see.
We would just look at key parts of information, but I don't recall seeing that specific quote at 10:20.
Okay. Can you help us with this? Do you have a mobile data terminal which sets out information from the control room, or how do you monitor a call?
Each air ambulance base has access to the CAD, computer-aided
Sorry,
dispatch.
can you just repeat that again?
Each air ambulance
air ambulance space.
station has access to the CAD, which you can see all live calls coming into the ambulance control room.
I see.
So the
that is-
mobile data terminal would be one we have on the vehicles, which gives you the information specific to the jobs you're responding to.
I see. So when you're in the vehicle, you have the mobile data terminal, but when you're in the air ambulance station, you have a different system called a CAD, but that would give you the information for live calls coming in.
All live calls coming in.
I see.
So back at HQ, they've got all of them, and you've got yours. Is that it?
From the control rooms, yes, sir.
Right.
Okay. And we can see from your statement at page 2, you say the initial call was a female not feeling well, taken some medication. It then changed to reaction to medication, and then a query anaphylaxis. Then the female was fitting. Do you see that on page 2? If we can pull up the statement, that is
Gone back to
document.
his statement, have you?
Yes.
Yes.
Document 5142.
Right.
Yes, ma'am.
Yes. If we could have page 2. Sorry, that's the wrong statement. Yes, thank you. And we can see the third paragraph from the bottom. It says the initial call was a female not feeling well, taken some medication, and then it changed to a reaction to medication. Do you see that?
Yes, ma'am.
Okay. Because we saw on the call log, and we don't need to pull it up, it said patient taken drugs. But here in your statement, we can see medication. So was your understanding at the time that it was a reference to medication that she had taken?
The impression I got from the call log was she'd taken medication because she was feeling unwell.
I see.
And later that day, when we arrived on scene, that was further clarified, the fact that she'd taken medication because she was feeling ill.
Because she was ill.
Because, yes.
Right.
I see. And so you had been monitoring the call, and you decided that you would attend.
Yes, ma'am.
You deployed with Keith Mills and Victoria Gilmartin. That's right, isn't it?
Yes, ma'am.
It took you 40 or so minutes to arrive at the location. Would that be a normal response time for you, or did you have difficulty finding the address?
We had difficulty finding the address.
Miss Pottle, is it relevant? He's not the first there. There are people already there attending to her. Is it going to make a difference how long it took them to get there?
Well, that's a matter for you, sir, but if you are not assisted by that evidence, we can move on.
Well, it's helpful to have necessary detail.
Yes. The call log records your arrival at 11:04. Does that sound about right?
Yes, ma'am.
Okay. When you arrived, you entered the property. You would have gone up the stairs. You entered the bathroom where Miss Sturgess was. Can you just describe to us what you saw?
It was a new build house, or flat, should we say. As we entered, I remember walking in. The stairs were wooden stairs, uncarpeted. Quite a steep set of stairs, and the bathroom was the first door off onto the right. Miss Sturgess was lying on the ground, kind of half in the bathroom, half out of the bathroom, with several ambulance personnel working diligently on Dawn at the time.
Could you see what treatment they were giving her at the time?
Initially, no, from the treatment-wise, but once we arrived on scene, we did actually say, let's have a pause and let's have a handover from the clinicians on scene already. And they were able to give me, Keith, and Tori a handover of what they found on arrival, what they'd actually done, the treatment provided, and where we were currently.
Okay. Can you just summarize for us what they told you?
From memory, I believe that the first paramedic arrived on scene to find and confirm Dawn in cardiac arrest. He set up beginning his normal treatment protocol, basic life support, until he was augmented by the ambulance crew. I believe initially it was a non-shockable cardiac arrest, I believe PEA.
Or, if I could just pause you there. Non-shockable cardiac arrest. And what did you say after that, known as?
Pulseless electrical activity, which is still part of the non-shockable algorithm.
Pulseless.
Pulseless.
Right, got it.
They had commenced ALS. It had gone from a PEA rhythm into ventricular fibrillation rhythm. One DC shock applied.
Okay, if I can just pause you there. So it had gone from pulseless electrical activity to ventricular defibrillation. Is that what you said?
Yes, ma'am.
Okay. And so that is, as I understand it, there was electrical activity in the heart, but it wasn't coordinated.
Yes, ma'am.
Okay. And then they gave a shock.
Yes, ma'am.
I see. And then what else?
One DC shock was applied, and currently they had a ROS, a return of spontaneous circulation.
I see. So you arrived, she had a return of spontaneous circulation,
Yes, ma'am.
and you said that you formulated a plan and you took over her care at that point. Is that right?
Yeah, when I say took over care, it's a team effort. We all provided input and care as all professionals. Because she was in such a profound low flow state, we had a shared mental model. We decided this was now obviously post-ROS.
If I can just pause you there, we had a what model?
Shared mental model. So we obviously came together as a bit of a brief, what the crews had actually done and where we were with Dawn. So
If these words matter, Miss Pottle, I'm not getting them, and nor is the shorthand writer.
I see. If I can just ask you, Mr. Thompson, to speak a bit more slowly, that will help all of us accurately record.
Don't worry
your
about it,
evidence.
Mr. Thompson. The trouble is, it's all very familiar to you, but sometimes the technicalities aren't to the people who are trying to listen. Do you follow?
So when we all came together,
Yes.
and we set about formulating a plan, it was to make sure we're all on the same level and understood what the plan was and what we were trying to do and deliver and where we want to get to. So it was a shared mental model.
A shared
Mental model.
mental model. Is that what? Yes. Okay. I think I understand. And so you formulated a plan out loud so that all of your colleagues could know and contribute to what the care was going to be moving forward.
Well and truly, it gave everyone the opportunity to explain and understand what we wanted to achieve.
I see. So, moving forward, after you had your shared mental model, what treatment did you decide to give to Dawn at that time?
I believe we looked at standard cardiac arrest management, which is full advanced life support, working through the 4 H's and 4 T's, which is the common causes of reversible conditions in cardiac arrest, and excluding what ones were not relevant, and obviously working on which ones was the more likely cause of the cardiac arrest.
Okay. And what did you think was the more likely cause of cardiac arrest in her case?
We verbalized that our biggest killer or biggest cause of this cardiac arrest was a neurological condition that's caused the cardiac arrest.
Okay. And what treatment did you give her?
Because she was in a post-ROS state, we took over the breathing and ventilation for the patient, delivered some fluids and some drugs, i.e. adrenaline, and supported her circulation. Working through the reversible causes, we delivered a drug called Narcan because of the eyes were initially pinpoint to rule out any form of opiate overdose as part of our reversible conditions.
I see. In your statement, you say that she was bradycardic and hypotensive and not making any spontaneous breaths at that stage. Bradycardic, that's a slow heart rate, is that right?
It is, ma'am, yes.
Is that common in patients who have been through cardiac arrest and have a resumption of spontaneous circulation?
It can be. The heart is in a stunned period post-cardiac arrest, and it's not uncommon to be bradycardic post-initially ROSC.
I see. And hypotensive, what does that mean?
She had a very low blood pressure, ma'am.
And was that common in people?
It can be, as I say, it's a stunned heart post-cardiac arrest.
I see. You told us that you had administered Narcan for a possible drugs reaction, an opiate reaction. And I think you told us that it was because her pupils were pinprick. Is that right?
They were initially pinpoint, and yes, as part of our reversible conditions, Narcan was given to potentially exclude an opiate overdose.
And did the Narcan have any effect on Dawn?
I don't recall having any effect on it at all.
To give her the adrenaline, which you spoke about, is it right that your colleague, Keith Mills, cannulated Dawn?
Yes, ma'am, I believe he cannulated Dawn in the bathroom.
Okay. And when he did that, did you notice that her skin was sweaty?
I don't recall, ma'am.
At that point, Dawn had an eye gel, which had been administered by the paramedics on the scene when you arrived. That's right, isn't it?
Yes, ma'am.
That's the piece of apparatus in her mouth, is it?
It is to assist and keep her awake, open, secure.
Did you notice at that stage that there were fluids around the eye gel or escaping from her mouth?
I'd have to refer just to the statement, but I can't recall.
I see. If it helps you, it's not in your statement at that stage that you had noticed that. Do you remember that there was a suction device that had been brought in?
Yes, ma'am.
Okay. And what was the suction device used for?
we would bring a suction device as part of every cardiac arrest is to clear the airway of any solid material or secretions.
I see. That would suggest, wouldn't it, that there were secretions then in her airway at that stage? If you had the
He's
suction
just said, Miss Pottle, that it's standard for every cardiac arrest.
Can I ask you, at that stage, do you recall whether you were satisfied with her airway management or not?
Whilst in the house, I was satisfied that the eye gel was working and we were able to ventilate effectively.
I see. In your statement, you say that you considered whether to replace it, but you decided against it because you didn't have 360 access to Dawn. Is that right? Yes,
that's correct on my statement. Due to the space within the bathroom and not enough space to have 360 access, plus it was working effectively at the time, it was decided not to replace it at that.
Yes, I see. We know that eventually you used a scoop stretcher to move Dawn down to the ambulance, and you noticed that she had defecated at that stage. Is that right?
It was when we moved Dawn initially to place the scoop underneath her body, that was when Dawn unfortunately defecated, yes.
Okay. Once she was brought down to the ambulance, you set about conducting a full reassessment of her, starting from head to toe. Is that right?
That's correct, ma'am.
Okay. And that assessment showed a heavy amount of fluid escaping from the eye gel, no respiratory effort, bradycardic her heart rate, and that she had lost the cannula in her arm. Is that right?
It is, ma'am, yes.
Okay. And did you know why the cannula had been lost from her arm?
It might have been in the point of some form during the extrication.
I see.
Well, during the business of getting her out?
Yes, sir.
I see.
At that,
And that's the reason why we carry out a full assessment. Once a patient's been moved and placed onto the ambulance stretcher, we would always carry out a full reassessment.
I see. You decided at that stage to change the eye gel and to intubate her during that reassessment. Why was that?
I believe we felt, certainly I felt, and the team felt, that we were at risk of losing the airway from moving from upstairs into the bathroom until we were on the stretcher. We'd actually noticed that her tongue had swollen to the degree that was actually pushing the eye gel up, and it was less effective of securing the airway.
I'm just trying to visualize it, Mr. Thompson. You've had to get her onto the scoop from a rather cramped bathroom floor, and then out what, down the stairs?
Down the stairs,
Yep.
outside, and that's when we noticed the tongue had actually enlarged with swelling.
Right.
And I believe, and the team believed, that we were at risk of losing the airway.
Thank you.
And you continued to treat her en route to the hospital. Is that right?
Yes, ma'am.
Okay. At that stage, her blood pressure was low, and you considered giving her atropine. Is that right?
Atropine was part of a team discussion. What else can we do to help improve and optimize the physiological symptoms of Dawn? So it was a consideration. Yes, ma'am.
I see. And you didn't give her atropine in the end. That's right, isn't it?
That's correct.
Okay. And why didn't you give her that drug?
It was a combination. With the tongue swelling up, it's almost as if it's having a reaction. What we didn't want to do is induce another drug into the system, considering we almost lost the airway with the large swelling of the tongue. And the other considerations we explored at the scene, that atropine would increase the heart rate, But what we really need to achieve was the blood pressure needed boosting, should we say, and therefore carrying on with the adrenaline, because it acts on two systems, it acts on the alpha and the beta systems, it would increase the heart rate, but also increase the blood pressure.
I see. So you felt that the adrenaline would be a better treatment because it would both increase the heart rate and increase her blood pressure.
Is to carry on with the adrenaline which we were administering anyway, and yes, it was a consideration of introducing another drug when we had a potential reaction.
I see. While you were at the address, did you discuss Dawn Sturgess's presentation with her partner, Charlie Rowley?
Yes, ma'am. I took myself away from the clinical side of the resuscitation, and I made a point to go and speak to Charlie to get a more detailed, in-depth history and past medical history of Dawn, so that would enable us to build the bigger picture of our treatment options and likely causes of the cardiac arrest that we were dealing with at the time.
I see.
Mm-hmm. And did you get that?
I got as much as I could possibly could, sir, enough to carry on with resuscitation and work my primary working diagnosis.
What did Charlie tell you about Dawn's medical history?
You can recall much of a past medical history from any conditions or diseases. So things like asthma, diabetes, he couldn't remember much of that. But he did say from a recreational point of view that Dawn was not an illicit drug user and she was alcoholic and never touched drugs, ma'am.
I see. We heard earlier in your evidence that you had been informed before arriving that she had taken medication. Did Charlie say anything to you about medication that she had taken?
Charlie, he did. Charlie recalled saying, or I recall Charlie saying to me that because she had felt unwell and had a headache, she had taken some medication to obviously relieve the headache because she was feeling unwell.
I want to ask you now to look at the electronic patient record, which is document 000655. It will come up on your screen, Mr. Thompson. Do you recognize that document?
Yes, ma'am, it's our APCR patient record.
Yes, electronic patient record. We heard yesterday from Mr. Coomer that he didn't fill this in and that you filled it in. Is that right?
I'm pretty sure I filled most of this in, yes, ma'am, yes.
And can you help us? How does that happen? Does any of it get filled in automatically from the machines, or is it something that you fill in?
From an ambulance perspective, at the time of Ms. Sturgess' arrest, we had a MobiMed, which is a device that connects all their devices and allocates it to the EPCR. But I believe on my statement, I recalled that the device, the MobiMed, was not charged and therefore didn't auto-populate onto the EPCR.
Okay, so it's supposed to auto-populate, at least some of it, but it didn't happen on this occasion because the equipment wasn't working.
Yes, ma'am.
If we can look now at the document, we can see that it records the time and date of the incident and the address. The patient, the primary survey says presenting condition cardiac, it's OOH cardiac arrest. Presumably that's out of hospital cardiac arrest. Yes. And then if we move then to page 2, we see, I suppose that's free text that you filled in, collapsed in toilet, went into arrest, RRV on scene, BIS commenced, that must be basic life support, is that right?
It is, ma'am, yes.
Ambulance arrived, commenced advanced life support.
Yep.
Extricated on scoop ALS, continued to hospital, pre-alert given. Fred Thompson completed the EPCR, all observations taken from the Zoll machine. And then if we can continue onto the second page. We have here a secondary survey conducted at 12:36, and then a record of the drugs interventions. And then if we move on to the fourth page, please. We have a record here. We can see the entry at 11:13. The drug isn't included, but it says 400 micrograms per nostril. I'm assuming that was the Narcan, is that right?
It is, ma'am. I've no idea why the drug name is not on that system, but it is Narcan, yes.
Okay. And then for treatment, we have cause of arrest, it says drugs overdose and other /unknown. How did that entry come to be put in? Did you type that yourself?
Excuse me, ma'am. No, ma'am. That is a drop-down list which is auto-populated when you click on that box.
I see.
And it
Oh,
gives
it's a multiple choice.
kind of, sir. It gives you multiple options of what,
Tick the relevant boxes.
if it's applicable. But in this case, because there was no neurological cause for the arrest on the automatic drop-down boxes, the other cause was selected. And then if you look to the right, it has free text where I've actually put in neuro, as in the neurological was the cause of the cardiac arrest.
All right.
I see. And so that I'm clear, drugs overdose and other unknown, is that part of the same option, or did you select the drugs overdose option?
It's all the same option.
I see. And so your opinion, when you filled out this document, was that the cause of her cardiac arrest was a neurological condition, is that right?
Yes, ma'am. We informed of a working opinion, having excluded all reversible causes, and with the information we had received and the presenting condition and treatment, our primary diagnosis was of a neurological condition that led to the cause of a cardiac arrest based on the history and everything together.
Mr. Thompson, just finally, we will hear from an expert in pre-hospital care in due course, and his conclusions are that the treatment offered to Dawn was of a reasonable standard. He doesn't criticize the treatment that you gave her. And furthermore, we have a causation expert who concludes that her poisoning was unsurvivable. But by the time you had completed your treatment of Dawn, you were aware that her symptoms included a fecal incontinence, respiratory arrest, and cardiac arrest, and that she had meiosis of her pupils. She hadn't responded to the Narcan. Did you consider that the cause of her symptoms might have been organophosphate poisoning?
No, ma'am.
Thank you very much. I don't have any further questions for you.
Good. Thank you. Are there any others?
Yes,
Yes.
if I may. That's right. Good morning.
Sorry, sir.
It's all right. I represent the family of Dawn Sturgess. Very few questions. If you could kindly cast your mind back to the period between the Salisbury events and the Amesbury. So it's just that period I want to ask you about. During that period, were there any meetings convened, multidisciplinary meetings, in which those who had been involved in the Salisbury events were able to pass on their experiences, their advice on the ground, as it were, if you understand what I'm putting to you, during that period? Did that happen at all?
I can't recall any, sir.
And may I make it clear that I'm indicating not just the paramedics, but scientists from Porton Down joining in and contributing and so on, that kind of thing?
Well, he won't know about that, will he, Mr. Mansfield?
Well,
what he can tell you is whether he was asked to any of them.
I appreciate. The point is whether there were multidisciplinary meetings involving him attending. That's the question.
Exactly.
Sorry, can I go back a step? I'm only talking about you. I'm sorry to focus on you and this period, as to whether you were invited to any multidisciplinary meetings which involved paramedics from Salisbury, scientists from Porton Down, all the people who've been involved in the Salisbury, passing on their experiences. From what you're saying, there weren't any.
I don't recall any, sir.
Thank you. Then there's no point in me asking you whether that training involved other things. Just one other question. From after Amesbury, after Dawn's death at that occasion, is there now training in place, training and advice, in order for you to distinguish, as far as is humanly possible, between those who might be afflicted by a nerve agent poisoning as opposed to opiate overdose?
We've got the national doctrine which for CPRN incidents, and that forms part of paramedic training. Yes, we have that, and there's regular updates provided through the National Joint Royal Ambulance Liaison College Committee guidelines.
Do you, I'm sorry, I'm not meaning to elicit any criticism of any kind. Do you feel that that training is sufficient for you to enable you to make distinctions of the kind I've just put?
From a professional perspective, it would depend on the incident you attended if there was any clinical intelligence to suggest organic phosphate poisoning or nerve agent poisoning.
Yes, thank you. So that's all I ask.
Yeah. Thank you, Mr. Mansfield. Mr. Thompson, thank you very much for your help. There's no need to stay unless you wish to do so. There's nothing else for him, is there, Miss Pottle?
No, there isn't, sir.
Thank you very much, though, Mr. Thompson. As I say, there's no need to stay, although, of course, you're free to do so if you wish.
Thank you.
Yeah. Yes, so we are now running a bit ahead of schedule.
Yes.
We have another witness to give evidence this morning, but sir, if...
Just one more this morning, is it?
Yes, just one more this morning.
In other words, you're delicately saying that you'd like me to break now.
I am.
Yes, all right. 11:05, please. Yes, Mr. Whitelaw.
Good morning, sir.
I do solemnly, sincerely and truly declare and affirm
that the evidence
that the evidence I shall give shall be the truth, the whole truth, and nothing but. Thank you.
Yes, please sit down if that's more comfortable, Mr. Chairman. That's
Thank you,
fine.
Good morning.
Good morning.
As you know, my name is Francesca Whitelaw and I ask questions on behalf of the inquiry. Thank you for attending today to give your evidence. Could you give us your full name, please?
Yes, it's Benjamin William Channon.
And I think, do you have in front of you a copy of a 6-page witness statement dated the 9th of July 2018 and bearing your name?
That's correct, yes.
The reference for the transcript is INQ 005542. And have you had an opportunity to read through that witness statement?
I have indeed.
And are you confident that the contents are true to the best of your knowledge and belief?
Yes, ma'am, yes.
Mr. Chairman, I should have said it before. Remember that people are watching and listening to you a good deal further away than Miss Whitelaw, in this room and indeed elsewhere. So make sure that what you say gets to those microphones, put them where they're convenient,
Okay.
and talk to them. Right.
Thank you. That's better.
So, with your permission, the whole statement will be adduced in evidence
Yes, it
and
will.
appear on the inquiry's website. If I could start with your professional qualifications and role, please. Were you in June 2018 a paramedic employed by the South West Ambulance Service?
I was, yes.
And were you based at Salisbury Ambulance Station?
Yes.
And again, from the uniform, is that still your job?
It's my job, but now I'm a specialist practitioner in critical care, so paramedic by background, but have since gone through further academic and indeed similar training to that discussed with Mr. Thompson previously. So my job now is going to those that are the most critically unwell within our region and working on an air ambulance within the region.
Right.
But at the time was a paramedic on the road, on an ambulance.
And at the time, for how long had you been a paramedic?
In 2018, that had been 3 years since qualification.
And Mr. Channon, were you here yesterday for the SWAFT evidence?
Yes, I was, yes.
In that case, I'll take the issue of training relatively shortly. But prior to March 2018, what, if any, training had you received about dealing with suspected hazardous chemical poisoning, whether that's nerve agent, organophosphate or other?
Yes, so prior to March, on induction to the previous ambulance service I worked for, and indeed South Western Ambulance Service, we have an online IOR training, so that's the initial operational response, which are online modules which from the NARI, the National Ambulance Resilience Unit, which I couldn't tell you the duration of it, but that's quite comprehensive on the recognition of symptoms and
Thank you.
treatment.
Could I just ask you to slow down with your
Sorry.
evidence, because we have a transcriber. Thank you very much. And so did that include then the recognition of symptoms for nerve agent poisoning?
Correct,
This is
yes.
prior to March 2018?
Correct.
And did it include symptoms for organophosphate poisoning
Correct.
generally? And also, did it include symptoms for drug overdose?
Not that specific training, but yes, I was aware of symptoms of drug overdose.
Had you seen, when you've seen in evidence a number of times, so I won't bring it up again, but the medicines protocol for duodote, which was dated January 2017, had you seen that prior to March 18?
Yes, yes,
So you were familiar with the symptoms that we've seen on the screen?
yes.
And after March 2018, did you receive new or updated guidance on signs and symptoms of nerve agent poisoning?
So it was the email in March disseminated from my, at the time, operations manager, Jane Wicello, on behalf of Mr. Dutch. That was an email with the, it was the repeat, there was no change in the guidance, but
Gently.
repeat guidance was emailed and issued. Yes.
So it was to refresh your memory
Correct,
rather than
yes.
specifically to introduce new matters?
Correct.
And do you remember when specifically that was, between March and June or not?
I can't recall the date. The 10th of March springs to mind, but I can't recall.
And You've heard some of the evidence that we've already had in the inquiry. Did you receive guidance specifically on the potential for confusion between drug or opiate overdose and nerve agent poisoning?
Not specifically, but that to me is a clinical decision based on knowing the signs and symptoms of both.
So what does that mean, Mr. Shannon? There wasn't any specific training directed to it?
I don't recall any specific training directed to differentiating between the two, but I'm aware in isolation of what both of those may look like. And then at the time, that's a clinical decision.
And were you or were you not conscious of the possibility of confusion, overlap, misdiagnosis between the two?
Yes, that's throughout medicine. There's always obviously the chance of two things looking similar, if that's what you mean, sir.
If we could move to the events of Saturday, the 30th of June, what shift were you working on that day?
So originally I was due to be solo manned on a rapid response car, as Mr. Marriott described yesterday, but presumably due to sickness I was taken from that shift to crew with Mr. Martin, who's present in the room, on a double crewed ambulance.
So was that a 6 in the morning till 6 in the evening shift?
Correct, yes.
And I think you've just said that you ended up working in an ambulance, is that correct?
Yes, yeah.
Which was double crewed.
Correct, yes, two people, yes.
And you mentioned Mr. Martin, is that Lee Martin?
Correct, yes.
And who was driving that day?
I was driving from memory.
And was the call to 9 Muggleton Road your first call of that shift?
From memory, we were tasked to another call prior to that, but the priority, which isn't uncommon, the priority of this call exceeded the priority of the previous call, so we were quite rightly diverted to this call.
Right.
You say the call was higher seriousness. What grade was the call to Muggleton Road?
I can't remember, but I know that Mark Faulkner's report definitely cites which priority that is.
So Mr. Faulkner says it was initially a Category 3 and then updated to a Category 2. Can you just tell us what those categories mean, please?
Yes, so a Category 1 call is immediately life-threatening, so that's someone who's not breathing or having severe respiratory distress or is having a seizure. A Category 2 is likely someone who there are questions that are quite specific on a triage system for that reason. Category 2 calls are often those with chest pain that may be a heart attack. And Category 3 calls, are often falls, non-injury falls, and other things like that.
So cardiac arrest probably would be Category 1.
It is, yes.
Right, and Category 2, something like potential heart attack, so still conscious, breathing,
yes,
but potentially very serious.
Correct, yeah.
If we could go to INQ 000656, please. We've seen a similar document for Dawn Sturgess. Do you recognise this as an ambulance record?
That's the record, yes. Yeah.
For the call that you attended to Muggleton Road.
Yes.
And was your vehicle call sign 7710?
Yes.
We can see at the top there, can't we? Vehicle call sign, and we have your name, Benjamin Shannon, and crew name, Lee Martin.
Correct.
And we see at the bottom there the time of call, 18:21, dispatch time 18:36, and at scene 18:47. I think that accords with your witness statement's
yes,
recollection of when you arrived at 9 Muggleton Road, 18:47. And what information did you receive in the initial call?
So the information, as my colleagues have alluded to, comes down onto a mobile data terminal. And on that information, on that screen, we'll receive the location, the category of the call, and indeed some of the basic details. The details I recall were again in Mr. Faulkner's report, and indeed the sequence of events, but I recall being sent to a gentleman that was reported as behaving strangely and hallucinating. Apologies if that's not verbatim, but that's what I recall similarly.
Well, we can see on the log there at the top, it says nature of call, hallucinations, making weird noises, not responding. And is that what you recall as well?
Yes, yes.
we can take that down, the document now, we'll come back to it. What happened when you arrived at the address? And do have your witness statement in front of you so that you can refer to it, and I'm on page 1.
Yes, so as I say, I was driving. We arrived to the address in Amesbury, arrived into the courtyard, and as per any incident, we'll always take a dynamic risk assessment. We were met by an adult gentleman that came downstairs outside the property. He appeared quite panicked.
Quite?
Panicked.
Panic.
And introduced himself and had reported that he was concerned there was a leak of sorts, and myself and Lee, probed that further.
If you could just take it a bit more slowly, thank you. So, first of all, a male came down quite panicked, introduced himself. But did you know him already?
So I knew of him, having lived locally and growing up in this area, and I know of him, but don't know him personally.
What's his name?
Sam Hobson.
Thank you. Ah, right.
Did you know his name before you went to the call?
Yes, yeah.
And I think in your witness statement you said he was at the same school as you.
Yes, yeah.
So
Older than me, but yes.
Did you know that Sam Hobson was involved with Class A drugs?
No.
So you've said that he appeared panicked to you. Did you think he was under the influence of anything or unwell?
No, not all the time, no.
So you said not at the time. Did you think that sin?
No, no.
And you mentioned that he said there had been some sort of leak. In your statement, you say, meaning a gas leak.
Yes, correct.
Well, that there was a leak, or that he thought there might be, or what?
So his phrase from memory was that he was concerned it was a leak, and then
Right.
probing from myself and my colleague were, do we think it's a gas leak? And he agreed.
Did he indicate that he thought that was because of the presentation of Charlie Rowley or for any other reason?
There was no comment on it.
So you didn't know if it was because of some sort of smell in the house or
No.
presentation? And what were your thoughts about what he was saying then?
That was a concern, and certainly a concern for his safety, our safety, and indeed the patient that we're being called to at the time.
And so what did you do then?
So we asked him to show us to the patient. As per always, as discussed, we'll take a dynamic risk assessment, but I could see from memory that the front door was open, and at that point we were content that we were going to approach with caution. We carried our first response equipment, which is standard to any call. And including that based on the concern that there was the word leak mentioned, we took our bag of personal protective equipment with us into the front door of the house.
So you had it with you in your bag, but not on at the time?
Correct, not on at the time.
And did you enter the property?
Yes, downstairs.
And how did you find Charlie Rowley? And please do refer to your statement if you need to. I'm on page 2.
So we walked upstairs as described into a kitchen area, approached at the door, and I believe Sam followed us up, but at that point I had no further conversation with Sam for the duration after asking him to go downstairs and maintain safety for himself and wait for further emergency services. I recall finding Mr. Rowley up against a wall, which has been shown on mapping in the sort of dining area of the kitchen. I remember Mr. Martin and I looking at each other and being very concerned that this was behaviour that was grossly abnormal in comparison to anything that we'd perhaps encountered before. And apologies for the terms, but Mr. Rowley was making noises very much like a cow and was making mooing noises essentially.
From when you came in, when you first...
Correct, yes.
Did you consider drugs a possibility at that point?
Yes, yes.
And what did you do next?
So, as I say, are you happy if I describe a little bit more? Because I think that's important about his.
Absolutely, yes.
So he was right. His face was against a wall, which clearly is not an obvious normal behaviour, and his hands were almost as if he was climbing down the wall. Obviously, we recognised that was really quite abnormal, and one of the main features that I noticed straight away was that he had what we've called as the hypersalivation, so profuse amounts of saliva coming from his mouth, which was really concerning. At that point, Mr. Martin, who, as I say, is present in the room, were very concerned that this was not normal, and given the information or the phrase leak that Sam had given us, we ensured that all the windows of the property were open to ventilate the property. So we walked over to the kitchen, opened the windows, tried to ventilate the room, and at that point, my statement should say we updated our control room of our concerns, requested at that time the fire service, and indeed donned the personal protective equipment that I describe.
So you put your equipment on, your PPE.
Correct, yes.
And in your statement, you refer to putting your protective suits on, along with overshoe protectors, a face mask with a filter and thin paper mask over that, and a protective visor.
That's correct, yes.
And the reason for calling the fire brigade
was the concern from the phrase, the leak.
in case of a leak.
And indeed the behaviour that I was concerned there was another substance.
Right.
So at that point, were you considering then some sort of poisoning from a gas leak and a poisoning from an unknown substance?
That's correct, and I think we were in a position by then where we had experienced the Salisbury poisonings. Working locally, then obviously we'd had advice, but kind of living and breathing in those times, it was certainly in the forefront of our mind. Certainly our safety was, and to be a lot more perhaps open-minded than particularly we were in the past to the chances of unusual substances, and that was the immediate concern that we had, and why we put our protective gear on, and thankfully we did.
At what point did you first consider the potential that this was similar to Salisbury?
So I don't want to talk too quickly, but we attempted a primary survey on Mr. Rowley. So to explain that's an evidence-based algorithm that is noted in the paperwork, and that's something that we use from catastrophic hemorrhage, airway management, down to breathing, circulation, and that's something that you'll assess every patient with. We'd established that Mr. Rowley had not displayed signs of catastrophic hemorrhage. He had an airway that was patent, despite some salivation. He was able to make noises. He was breathing effectively enough to remain stood, and clearly the assumption was that his cardiovascular system at the time was supporting him being stood up. At that point, we moved on to disability, which is an element of that assessment, and Mr. Rowley's behaviour was abnormal. Obviously, we tried to introduce ourselves and reassure Mr. Rowley, but his conscious state was not at a point where he could converse with us. To note, Mr. Martin attempted to put his hand on his shoulder to reassure him, but indeed to also move down and take a radial pulse from his wrist and apply some of the monitoring equipment.
Before we go further on, if I could just take you back a little bit, so we'll come on to more of that. I just want to make sure we've got each point as we go. Could we just go back to the log, which was INQ 000656, please? And could we go down to the next page? So here it says called to attend a gentleman who was reported behaving strangely, salivating profusely, making strange noises. Alerted on arrival that a female at this property today was taken to hospital in respiratory arrest due to an unknown cause. Question mark, drug related. So first of all, do you recall at what stage you became aware that there had been a patient earlier in the day from the same address?
Yes, so although I've put on arrival there, from recollection, that was a radio transmission message from our dispatcher en route to the incident in the ambulance itself, advising us that there had been an earlier patient at that address.
And how, if at all, did that impact your assessment at the scene now that you've seen Charlie?
So initially, my thoughts were that this was likely to be a gentleman who's emotionally upset and distressed, given the story around the behaviour, knowing that his partner was clearly critically unwell earlier on in the day. However, if you look at the steps 1, 2, 3, and that's been cited throughout other evidence that I've viewed, the number of patients, so now our thought process that we've potentially had 2 patients at this address that had...
So that's one of the things I wanted to ask you. The 1, 2, 3 guidance and counting the numbers, that doesn't then need to be counted at the scene if it appears that there are numbers within the same circumstances. Is that right?
That's certainly how I interpreted that guidance, yes.
And can I just ask you a question? Where there is a question mark before drug related, is that relating to the female patient, a question about whether that was the cause there because it says unknown cause, or was it to do with Charlie Rowley, or was it both?
I can't recall where that information has come from, whether that was something that was passed to me, but obviously will be available via the transcripts. I don't recall that being something that Sam had told me, so I can't recall where that information came from. Obviously, unfortunately, Mr. Rowley was unable to talk to me at the time.
So we see the rest of that entry on the log, approached with caution, and due to recent events within Salisbury and the nerve agent attack, crew decided to don PPE by way of suits, mask and shoe protection, which you've described. Steps 1, 2, 3 followed as per hazmat guidelines. Again, is that the CBRN
It's
process?
hazardous materials, yes. Yeah.
Arrived to find gentleman GCS 11. Could you just explain that?
Yeah, so GCS is a Glasgow coma score or scale, and that scales from 3 to 15, and you score points or reduce points based on response with eyes, voice and motor function. A score of 3 is deeply unconscious. A score of 15 is how we are now in this room. And Mr. Rowley originally was GCS 11, so he, as I described, was making noises, had increased muscular tone, but wasn't coherent in a way that I could have a conversation with him.
Can I ask you about that? It says increased tone to upper limbs. What does that mean?
Yes, correct. So that was the probably to me the most bizarre sign that I've seen. So when I'm talking about increased tone, I'm talking about increased muscular tone. So as we're sat here now, our muscular tone obviously is affected by what we need to do and reach and move to things. But this was a muscular tone that was fixed and rigid. And when Mr. Martin tried to move Mr. Rowley's arm, he was unable to do so.
So like paralysis, is that?
Not paralysis. This was the opposite of paralysis. So rigidly increased tone. Can I explain?
Yes,
yeah.
please do.
So you would see increased tone in patients that are having seizures. So fitting, but including with that, you would see what we call clonus, so the shaking as well. And often patients that are potentially having an intracranial or a neurological event, you may well see increased muscular tone as a part of that. But what I note is that this muscular tone that we both saw was different to anything we'd seen in our experience of other presentations of neurological events, seizures, or indeed use of other substances.
And then to continue on, making incomprehensible sounds, which you've described, leaning up against a wall. A patient was not responding to commands, had pinpoint pupils. Was that unusual?
Yes, so pinpoint pupils were noted. I think it's important to note at this point it was very difficult to do an assessment on the gentleman given his conscious state was at a point where we were really struggling to be able to apply monitoring equipment and indeed open his eyes and assess him. As I've alluded to, his conscious state reduced and at that point we're able to look into his eyes and establish the pupils.
Just to continue on the symptoms, sweating, salivating profusely you've dealt with. Initial observations as recorded, we'll come back to the point you were describing of taking observations. I just want to cover while we're on this page. No drug paraphernalia present initially. Drug use was denied by the occupant.
Yes, and that's Sam, not Mr. Rowley himself.
What I was going to ask, thank you. So does that mean that, one, you considered the possibility of drugs in this case?
Yes.
And two, the initial indications to you were that there weren't any obvious indications either from Sam Hobson or from anything you can see.
So there was no history of, but as per a differential diagnosis in any collapsed patient or with altered behaviour, certainly very commonly we'll see patients that have used recreational substances that would describe or the behaviour would be attributed. So it was a reasonable consideration at the time in conjunction with the constricted pupils that you'll often see in opioid.
Just pause a minute, Ms. Whitelaw. I may have encouraged this unnecessarily, Mr. Channon, but I'm told that you're now sufficiently close to the microphone to be occasionally distorting what comes through people's headphones. So you'll have to find a happy medium. Just a little bit away from it, please.
Thank you.
And it says EOC informed. What's EOC?
So EOC is our Emergency Operations Centre.
And heart requested, so specialist teams.
The hazardous area response team, yes.
Tell me, Mr. Channon, what we're looking at, which is the record, is it filled up, as it were, on the run as you go along, or at different stages during the day, or when you get back to HQ afterwards? How does it work?
Yes, so this is the clinical record. So given clearly the treatment was a priority at the time, this patient record is completed at arrival at hospital once the patient has been handed over, and then that's contemporaneous notes following that event.
So it's a report when you get back to the hospital?
Correct, yes.
Thank you.
And bronze requested, what does that mean?
Bronze was a term which is now outdated, and that's now replaced with operational commander.
Is that for the ambulance service?
Correct, yes.
And then 7:25, patient slowly collapsed to floor, became GCS 8, so a deterioration in the Glasgow coma score.
Correct, yes.
And then it describes the treatment, which we'll come on to in a moment. Could we go, please, to INQ 000654? And is this the ambulance call log? We've seen it before. I'm afraid this is a difficult document to follow. There are only a couple of entries I just want to take you to, please. The first should be on page 13. And I'm looking for an entry that is 191150, similar to pre-Sal incident.
Down a bit. Yeah, down a bit, I think.
Yes, it's the capital letters, a couple of lines down from there. Similar starts on the line below the highlighting. So if we could highlight the word similar just below the current highlighting. Thank you. And then a few lines down, the next where it's a set of capital letters, to Prev Sal incident. Thank you. And then if we could just go to page 16, which is 1928-19. And I'm looking for the entry LP993. I think it's advised he and 7710 both attended previous SALS incident and state along with fire PTS presenting with similar incident. So that's at the bottom.
Highlight that for us.
Thank
That's
you.
It, that's it. One.
LP 993.
Down to similar incident.
Thank you. So first of all, I think you said the call sign for your vehicle was 7710, is that correct?
That's correct, yes.
Is 993 another call sign?
Yes, so 993 is a rapid response vehicle, and that was crewed by Mr. Parsons, the operational commander.
So does it look like that means that Mr. Parsons, we think it's Mr. Ian Parsons, advised that he and he's referring to your ambulance call sign, so is that you or Lee Martin attended previous, I assume, Salisbury from Sal's incident? Did you have any involvement with the Salisbury incident?
I didn't attend the patients, no.
But had Mr. Martin.
I don't believe Mr. Martin did, but Mr. Parsons had.
But Mr. Parsons had. I see.
Thank you. Thank you. We can take that down now. I want to return to the developing prognosis and treatment given to Charlie Rowley at 9 Muggleton Road. So when you examined him, you've described what you say in your statement, which is the mooing like a cow, salivating more than you would usually see. We're still on page 2. Sweating profusely, pupils very small, which is the same as what we've seen on the log already. And you've described you not thinking that's a normal presentation. In your statement, you say, I thought this was not the normal presentation of a drugs overdose, which we thought it initially could have been. Can you tell us then next, you've already explained that you Lee walked over to Mr. Alley and put his hand on his shoulder, tried to get him to sit down on the sofa, and the stiffness meant he couldn't. You've explained the muscle tone. You were talking, I think you got to monitoring levels, so do refer to the statement if you need to. Did you
Yes.
take his temperature?
Yes, so at that point, apologies if I'm speaking too quickly, we began our assessment of him and, as alluded to, using the primary survey as discussed earlier. With any unconscious patient or collapsed patient, unfortunately, obviously, they're at a point where they can't give us a medical history. So we're then relying on physiological measurements. When I say that, I mean, temperature, blood pressure, heart rate, things that we can measure pre-hospitally. So one of our concerns at the time is this, as I say, as a result of, when I say intracranial, so something inside his head, whether he was perhaps having a brain hemorrhage or whether there was, in fact, a horrible infection that was impairing his behavior at the time. And a temperature, a raised temperature may have demonstrated the signs of an infection. And indeed, a blood glucose is really important in those patients because we know that a low blood glucose often affects behavior. So they were done as immediate observations because they were easy to achieve when Mr. Rowley was moving around, where applying a heart rate monitor or blood pressure cuff as such was quite difficult and would often throw us spurious readings when someone's moving. So.
And what were those readings that you took from him? Were they normal or abnormal?
Yes, and obviously documented on the clinical record, but I remember his temperature was normal and his blood glucose was within normal limits. So that reassured us that it was unlikely that hypoglycemia or low blood sugar was the cause of this behavior at the time.
So we've got normal blood. You could take his temperature and it was normal.
Correct. Yeah.
You could check his blood sugar and that was normal.
Correct.
You couldn't decently check his blood pressure because the equipment doesn't work in the condition he was. Is that it?
Yes, sir, yes.
Got it.
And I think in your statement, and we're at page 2, the action you take, which you've alluded to, is calling up control. We've also seen it on the log. And you say asking them to call police, fire, clinical backup and HART, the hazardous area response team. I think you knew the person who answered the call, is that correct?
Is that the lady I've referenced as Holly?
Yes.
So know her through frequent conversations on the radio. I don't know her personally, but know her by name.
So a dispatcher with whom you're familiar?
Yes, correct, yeah.
And what did she say when you asked for those resources?
She was obviously going to send those resources, but I recall her confirming whether we would like the operational commander to come manage the scene and that multi-agency communication that was likely to be required.
And who was that, the operational manager, that you thought was going to attend?
So the on-duty operational manager was a gentleman called Richard Tilsley at the time. So within the area, was there a county-based resource, a specialist resource. So often their run times are slightly longer. Mr. Parsons was on a response car in Salisbury and suitably trained to fulfil that role in the interim, hence his immediate dispatch to us.
So were you seeking at this point a multi-agency response?
Correct, yes.
And was that in accordance with what we've heard Deputy Chief Constable Mills explain in his evidence, the Jessup principles?
Correct, yes.
And after you'd spoken to your control, you indicate in your statement that Lee Martin phoned Salisbury District Hospital. Could you tell us about that call, please?
So I remember Lee making that phone call. So that was moving down what I've described as our differential diagnoses. So we were at a point where none of the measured physiology, so the numbers that we were receiving from Mr. Rowley were pointing to a clinical picture of an infection or a significant head injury or the use of a substance such as cocaine or indeed opioids. So as part of gathering a collateral history in the absence of anyone that was able to give us any medical history of Mr. Rowley, it was thought that a sensible option was to phone the hospital. Given the information we'd received prior that sadly Ms. Sturgess was acutely unwell and taken to the hospital, Mr. Martin felt it prudent to phone the hospital and ask to see whether there was anything specific that she'd become unwell as a result of, and whether that would help us identifying our condition with Mr. Rowley.
And he phoned on a particular line, didn't he? Could you just explain that?
So it's probably documented as the red phone, and that's a protected line that we provide a pre-alert to the receiving hospital on. So that's a line that they'll always answer within a rapid fashion.
And he had a conversation with, I believe you describe it, a sister.
Yes.
Called Vicky.
Vicky, yes.
About the clinical features of the female. Do you remember what did you hear the conversation?
I can't, I'm sure I heard it, but obviously I was managing Mr. Rowley and I don't recall the details of that conversation.
Could you tell us firstly, if you recall what Lee Martin told the hospital?
Mr. Martin, I remember him explaining the presentation of Mr. Rowley at the time, and then obviously requesting to see what they were perhaps treating Ms. Sturgess for. Clearly there's an element of patient confidentiality, and giving information quite rightly over the phone is not necessarily the done thing. I don't recall the response that Mr. Martin received, but I appreciate he's present in the room and perhaps would be able to help with that.
Well, in your statement you say Vicky told Lee she would find out and call back as soon as she could. Do you know if there was a return call?
There was a return call, yes.
And how was Charlie Rowley presenting by this point? And this is the end of page 2, if it helps you.
Yes, so by this point, Mr. Rowley had deteriorated in terms of his conscious state, and we were assisting him slowly to the floor. And I remember having the discussion with Lee that at this point we were preparing for Mr. Rowley to deteriorate to a point where he may enter cardiac arrest, and therefore we prepared for that appropriately.
And when you say you prepared, what do you mean by that?
So we went through our stepwise approach of airway management as listed in the documentation, applied defibrillator pads with a view that if his heart was to go into an abnormal rhythm, we could treat it with energy, and optimised his physiology as described on the clinical record.
And I think you had some difficulty opening his jaw to apply oxygen. Could you tell us about that, please?
Yes, so I've described that as trismus, so that's because of the increased muscular tone in his jaw at the time. That was very difficult to allow me to place an airway adjunct device to open those airways.
So the muscular tone that you're describing is the muscle, as it were, in stress, is it?
Contracted.
Contracted, and hence difficult to open the mouth.
Yes,
I see.
correct.
And so what did you do about that? How did you get the oxygen?
So in that instance, I used a device that I've listed as an NP, so that's nasopharyngeal, so that's an airway tube that goes in through the nose, because I was unable to open the mouth, and then that sits at the back, moves round the tongue, and then hopefully ensures a patent airway as a result of that.
Did that seem to work?
I remember that improving his airway, and obviously the application of high-flow oxygen through a mask also.
And what about achieving intravenous access?
Intravenous access was attempted on both hands, I remember, both by myself and Mr. Martin, and there was nothing that was obvious in terms of visible veins and palpable veins that we could feel. We'd attempted that a few times but had failed.
Was that because of the rigidity, or was that another reason?
That's not uncommon in someone who's so critically unwell that their vascular system is compromised to a point where it's very difficult to obtain IV access, yes.
And did you give him naloxone?
Yes.
And how did you administer that?
So the first dose was intranasally, and that was due to the absence of, or the inability to obtain intravascular access. So that was into the nasal mucosa, and that's using a small device that atomizes the medication.
And we heard yesterday that helps reverse the effects of opiate overdose.
Correct, yes.
Did it have any effect?
It didn't have any effect, but the indication for that was the small pupils.
And what did that make you think?
Initially, I thought that maybe we needed more of a dose. I remember giving him 400 micrograms and then a repeat dose, but was concerned with the increased muscle tone and the salivation that this was not a classic opiate overdose. Wouldn't expect to see necessarily the increased muscular tone and salivation to that level with an opiate overdose, which I've seen many of.
So in combination, the lack of reaction to the naloxone, the small pupils, the salivation and the muscular tone, were those the main factors that were making you think this wasn't an opiate overdose? And was the conclusion that you were thinking it was a nerve agent poisoning, or were there still other things that were in your mind?
Correct, at that point. I remember, obviously, we'd worked through the differential diagnoses as described with infection and stroke and head injury, and the use of substances such as cocaine, which would perhaps induce seizures and some of that increased muscle tone. There was no evidence of that, and obviously it's a consideration, but there was no one to confirm that. But the behavior that we noted was vastly different to anything we'd ever seen. And I appreciate at the time I was a paramedic of 3 years, but had seen plenty in that time of recreational drug use, and feel that I had enough experience of other medical conditions that this looked vastly different.
What was the most likely thing that you thought it was at that point?
At that point, Mr. Martin and I came together, and Mr. Martin suggested, he said, this is very similar to what we've learnt about following the Salisbury incidents. And that clearly is advice we were given, but indeed continuous professional development in terms of discussions that we have with other healthcare professionals, clearly mindful of patient confidentiality, but self-directed learning through fear mostly, following the exposure that the Scribbles had.
And then you go on to describe Mr. Martin inserting drills. Can you just explain that process, please?
Yeah, so that was due to the failure of intravenous access. That's a device called an intraosseous device. So that's a catheter, that goes into the bone marrow and allows us to very quickly and effectively deliver medications in the absence of vascular access, and is very, very commonly used in cardiac arrest, but less commonly used in conscious patients.
So did you deliver medication at that point using that?
Yes, at that point he had the atropine.
So in your statement, I'm now at page 3, what did you use to administer the atropine?
So from memory and indeed the clinical record, the duodote intramuscular atropine pen with the pralidoxine was given prior to the intraosseous pure atropine, if you like. So the pure atropine, to answer your question, was drawn from a small vial, checked as per protocol. We have, as alluded to earlier, indications on our application. So we check the medicine, administer the medicine based on the indications that we see at the time. And then that was delivered through the intraosseous route.
And what was the intention of administering that?
So at the time, if I can go back, we'd recognised that this was abnormal. We'd had the discussion that in the absence of any other obvious pathophysiology or symptoms, everything at this point was pointing to someone who was incapacitated from what we believed to be the potential of nerve agent poisoning. Clearly, we are unable to diagnose that pre-hospitally, but what we can do quite well is treat symptoms of that, and we felt it prudent at that point to administer this medication. We gave the intramuscular dose of the atropine, so that's the duodope pen that we've spoken about, and that's a combination of drugs, so that's atropine and pralidoxime. So that was given intramuscularly into Mr. Rowley's thigh, and that was administered by Mr. Martin. And then to answer your question, a time after that, which again will be reflected in the administration on the clinical record, we gave the atropine. And the atropine is an anticholinergic drug, and what that means is that reduces the effects of the nerve agent on the parasympathetic nervous system. So when I say that, it reverses the mass secretion that we were seeing that was causing an airway compromise on this gentleman. So the dose of the atropine, 600 micrograms, was in addition to the original intramuscular dose of duodote, and this was to reduce the secretions that we were seeing and combat what we thought at the time had potential to be nerve agent or organophosphate.
Did you see an immediate response to that?
There was I wouldn't say an immediate response, but there was certainly a reduction in the salivation in time, as one would expect to see giving that drug, yes.
And I think in your statement you indicate that Charlie Rowley was fitting at this time.
Yes.
And so what treatment did you give for that?
So he began, as I say, he'd had the rigid muscular tone, and that was a persistent thing, but he didn't have the accompanied, what we call the clonus, so the shaking element of the seizure. In that time, obviously, we recognised that his conscious state had unfortunately progressed to the seizure, and he was administered a benzodiazepine class of drug called diazepam, and that was administered initially in tentative doses based on my concern that he was already a compromised gentleman. So he had 2.5 milligrams of midazolam, which is a reasonably small dose, considering an adult would have probably maximum of 20 milligrams initially.
And what effect did that have?
So that in combination, I believe in total he had 7.5 milligrams over a duration that stopped the seizure.
And did it affect his jaw?
Yes, so in combination, that drug allows muscles to relax, and that allowed us to optimize the management of this gentleman's airway a lot better, yes.
And you've described already, I think, the further dose of atropine through the
Yes.
IO device. You say in your witness statement that you and Lee Martin agreed you needed critical care, but you weren't sure whether it was coming. Why was that?
I think because certainly now, unfortunately, due to COVID, we're very used to working in PPE, but at the time we'd requested lots of things, and if I'm honest, I think we were both particularly scared. And I recall asking for these things, but I don't recall what the response was. And clearly, I certainly never left the property in the duration of care, so wasn't sure whether that had arrived. But certainly, no one had come into the property.
Were you getting any communications about what was happening outside pursuant to your request?
So yes, there was confirmation from the control room, as I said when we spoke to Holly, that those requests were being processed, and indeed. By this point, Mr. Parsons was outside having conversations with multi-agency partners.
Did you know that? Were you in communication?
Yes, with him directly, yes.
So you understood by that point you were dealing with nerve agent poisoning. That was your understanding.
I believe, yes.
Obviously subject to a diagnosis in hospital. You'd asked the dispatcher for a multi-agency response, and you weren't sure why no one was yet coming.
Yes.
So you hadn't been given a time estimate.
No.
Did you make preparations then to get Charlie Rowley into the ambulance yourself?
That's correct. I remember Mr. Martin going downstairs and collecting the appropriate equipment, so a scoop stretcher and such.
And were you managing his airway at that time?
Yes, yes.
And I think you also had to move the ambulance, is that correct?
I don't recall that myself, but that sounds reasonable, yes.
So at page 3 of your statement, you say that that was Mr. Martin, so that would explain why you don't recall yourself being involved, but you said he'd also moved the ambulance forward as the ramp would not come down. And how was Charlie Rowley at that point while you were making preparations to get him into the ambulance yourselves?
Yeah, so I remember him still having a residual increase in muscular tone, but he was no longer fitting. So his airway was being maintained with the devices as described. He was self-ventilating, so he's breathing for himself, but at times needed a little bit of assistance. That may be because of the underlying nerve agent that we now know was causing that, but that's also often a side effect of benzodiazepines, of slowing the respiratory rate, and that's something we understand and can manage, and is indeed easier to manage than the seizure. So supporting his ventilations as described. And
was he still making noises?
he was, yes.
And I think you said yawning at that point.
Yes, yawning a lot, yeah.
Was that unusual?
That was unusual, yes. I've not seen that before.
And then coming to the involvement of Ian Parsons, you've indicated that you were in direct communication with him on the radio.
Yes.
He was the lead paramedic, is that right? And we've heard that that's a sort of...
It's a managerial role, yes.
Exactly, thank you. And did you understand while you were in the property that there had been a cordon organised outside the property?
That was, yeah, so we moved on to a open talk group. So in the ambulance service, we talk point to point on our radio system. So unlike the police, we don't hear what's going on in the local area. But at this point, on incidents like this, we've been moved to that group. So we were able to hear on the radio that had been put in place by Mr. Parsons outside, yes.
So you're inside still at this point.
Correct,
But
sir.
you're in open radio communication, are you? First of all with Mr. Parsons outside, and also with the police loop, did you say?
Not connected with the police at that time.
Not the police.
So by this time, you understand there's a cordon outside, you're onto the open group so you can hear what's going on. Had you communicated to Ian Parsons directly that this seemed to be nerve agent poisoning?
Yes, we'd had conversations between Lee, myself, and Mr. Parsons that was our working diagnosis at this time, yes.
And I want to move on to the search of Muggleton Road and the extent of your involvement in any search. What did Ian Parsons say to you on the radio? And this is your page 4 if you need to refer to your statement.
I'll just read the statement first. Is that in the second paragraph?
Just
No.
It's actually
Yes,
at the very
I see.
top.
As described earlier, Mr. Parsons had been involved in the earlier incident, understood where we were coming from when we were describing the symptoms and understood.
Just to clarify, he'd been involved in the Salisbury incident.
Correct, yes. So he understood our concerns and fears that this may be a repeat. He obviously was outside, presumably with multi-agency partners, but I don't know at that point for certain. And then
Sorry, could you just repeat that? You thought he was outside, presumably with...
our so police and fire.
And what did he ask you?
And then at that point we were asked to have a look in the address and see whether there are any signs of drug paraphernalia that could potentially attribute the behaviour to another substance.
And you hadn't seen any up until that point.
Correct,
You
yes.
said earlier. So where did you look?
So obviously had a look around the kitchenette area originally, and then looked through the kitchen itself, so opened cupboards and around.
So just before we go to the kitchen, did you see anything in the lounge area?
The lounge area where the patient was.
Where the sofa was?
No, I don't recall anything there.
So you didn't, did you look in there? Because you say in your statement, I didn't see anything in the lounge area.
Yes, there was nothing in that area. So looked in sort of on windowsills and things, but there was minimal furniture and things in there. So there was
So nothing on the floor, no syringe. No. Did you use syringes in the course of treatment?
Yes, yeah.
And would they have been still in the property when the police arrived? All the medical equipment that you've been using?
The police to search, or the police as part of the emergence?
Both. So first of all, the first police officers that came in, at that time, was there medical equipment, including syringes, around?
Yes, they would have been next to the patient.
But when you came to leave in the ambulance, does all your equipment go with you, or does it get left to clean
We
up
always
later?
try our best to remove specifically sharp needles and things that comes with us, but obviously the human factors element of trying to remove a critically unwell patient, there may be a syringe that was left behind on the floor.
Thank you. So then you go to the kitchen. In the statement, you said you were opening drawers and cupboards that you could see, and in the cupboard on the left-hand side of the kitchen window, what did you see?
Yes, I recall opening that, and as in my statement, there were needles and syringes in that cupboard, yes.
And how did they appear? You said in your
like the
statement
use of
they appeared
intravenous.
either used or ready for use.
Correct, yes. Yeah.
So not brand new and unopened, is that what
Not
you
in
meant?
packets, no.
Not in packets. And you said there are a couple of other syringes, I'm not sure exactly how many. Could we just go to INQ 005529 and page 4, please? You may have seen, we've seen this document in evidence before. I just wanted to confirm with you, you indicated that you looked in the kitchen in a cupboard to the left of the windowsill. So is that below the star there where we see info
Below the micro-
placement of
yes.
perfume box? Was that the cupboard where you saw the syringes?
I believe so, yes.
Did you do anything with them, or did you just leave them there?
No, saw them there, and at that point it was beneficial to aid us that this may be someone that uses intravenous drugs.
Were you still wearing protective clothing when you were in the house looking for the drugs?
Thankfully, yes.
And did finding that drugs paraphernalia change your assessment that this was nerve agent poisoning?
I don't recall it. It certainly added to a wide array of differential diagnoses, but at this point, the behaviour, when I say behaviour, the behaviour of the patient, to me was vastly different of someone that would have used heroin, for example. So to answer your question, we continued with our working diagnosis that this was organophosphate or nerve agent poisoning.
And did it affect your treatment in any way?
No.
I'd like to just ask you now, we can take that down, thank you very much, about interaction with other responders at 9 Muggleton Road. So could you tell us what happened next?
Yes, so as referring to my statement, there did feel some pressure from outside to look for other signs of drugs within the property to try and perhaps rationalise the symptoms of the patient, because clearly nerve agent, thankfully, and until this has been particularly rare as an occurrence in this country. So quite rightly, we were being asked if there's anything else we could truly attribute to the symptoms.
Where was that pressure coming from?
So that was on a radio. I can't recall who that was from, but yeah, that was from either the emergency operations centre or one of the command team outside. But as I say, at that point we were all on one channel, so it's difficult to recall who exactly that was.
And so was that even after you'd found some drugs paraphernalia? Or
That's what prompted
prior
the
to that?
search.
Okay.
Yes.
And so I think there came a time when 2 police officers entered the property. Can you tell us about you seeing them and your reaction to that?
Yeah, so I recall being on the kitchen floor and managing the airway of Mr. Rowley and Mr. Parsons and Mr. Martin. We'd agreed a plan over the radio that 2 members of the fire service were going to come in enhanced protective equipment to come and help us extricate this patient. So where we heard footsteps coming up the stairs, as I've cited in my statement, and we kind of shouted out, and we presumed these would be people in protective equipment, but 2 police officers arrived without protective equipment, and I was fearful for their safety and advised them that they needed to don appropriate personal protective equipment before coming forwards.
Were they wearing gloves?
I recall gloves, but nothing else.
Okay, because in your statement you say didn't even
I say
have
not gloves. Okay.
gloves on. So,
Eventually they were wearing gloves, but yes. Not.
okay. And so how did you advise them to don protective equipment, and what was their response?
As Mr. Mills said, they were overly confident that this was likely a drug overdose as opposed to anything else. So we're confident that my interpretation is that they were happy with the level of protective equipment they had at the time.
And what was your reaction to that?
My reaction was, clearly thank you for that additional information, but I remember distinctly saying, clearly quite frightened at the time, what in your knowledge is making you think that this is something other than the nerve agent that we're using as our initial working diagnosis. And I can't recall the conversations, but I remember them becoming heated but not rude as to, we're really concerned, please could you share some information with us as to why you're so certain that this is not nerve agent poisoning.
And did you get any more information about that?
I don't
No.
recall any information.
And did you make clear to them that your working diagnosis was that this was nerve agent poisoning?
From memory, yes.
Were you aware did they tell you that there was police intelligence relating to Charlie Rowley's use or involvement with drugs?
I can't factually record that, and that's obviously, I'm aware from hearing evidence over the last few days that that was the case, but I can't recall that that was given to me at the time, no.
We've heard and are likely to hear more about Charlie Rowley having used heroin before he was poisoned with Novichok. Would that affect if you'd known that, would that affect your treatment?
Affect in a way that it would be a sign of a reversible cause for someone that's collapsed. But as I said to you, this behaviour was very different to the many opiate overdoses I've seen, and I wouldn't expect, in my experience, but certainly I'm no expert, to see the hypersalivation and the muscle rigidity and the noises to the degree with the opiate poisoning, the pupillary response being constricted, I could attribute to a crossover, but this to me appeared very different.
So, sorry, I'll be clear in what I'm asking.
Okay, so
the combination of taking heroin and being poisoned with Novichok, would that require different treatment, given that you've already said you've administered the Naxalone, which was for opiates, and the atropine, the Duodote? Would there be anything else? If you'd known he'd had both heroin and Novichok, would there have been anything else you'd need to give?
Only the airway support that we did and the repeated doses of naloxone. So as you'll see, that featured, and we repeated, I think, up to 1,600 micrograms, which is a fair dose of naloxone, with remaining open-minded and with the pupillary response. We continued to administer naloxone in conjunction with other treatment to cover both bases, yes.
So you were giving all the treatment that you would have done had you known that there was heroin as well as Novichok?
Absolutely, yes.
Did the officers help you to get Charlie Rowley to the ambulance?
Yes, they were very helpful, yes.
And did you update, you say in your statement you updated the major incident channel. What's that? Is that the open channel or something else?
Yes, so by this point, clearly the information that we'd given in our situation report had been relayed to the Emergency Operations Centre. Indeed, the command structures were now formulating, and Mr. Parsons obviously was leading that. There are certain procedures which are probably better directed to Mr. Faulkner's report, but that all becomes set up, and then we were pushed on to this, what we call a major incident talk group, which allows all necessarily interested parties within the ambulance service at that point to be on the same channel. So my update at that point was heard by all that needed to hear.
So first of all, what time was that, by reference to page 4 of your statement?
via radio. So that's 39 hours as per my statement.
And am I right to understand then that the ambulance, as far as you were concerned, the ambulance service was preparing for a major incident or using procedures that would do?
Correct, yes. Yeah.
And I think there came a point when the police officers got in the ambulance to drive to the hospital once you got Charlie in the ambulance. And what was your reaction to that?
So that to me is not standard practice, certainly, but perhaps retrospectively, and the command decision element was probably of a view that at this point these two individuals had been contaminated anyway. So rather than expose further people to contamination, it was agreed as a command decision that they would safely drive us to hospital.
So did you get authorisation to travel to the hospital?
Correct, from Mr. Tilsley.
Can I just ask you, before you departed, you'd obviously come out of the property to get Charlie Rowley in the ambulance. And what did you see all around you when you got out? I can't recall anything other than, thankfully, Mr. Martin had reversed the ambulance quite closely to reduce the amount of distance we needed to carry the patient. Obviously, I've seen retrospective footage on the news, but I don't recall anything significant at the time, and I certainly don't remember being met by anyone. What I remember is myself, the patient, and two police officers were the only people I could see. So you didn't see emergency vehicles? They may have been there, but you didn't.
I remember a fire appliance being in that courtyard as well.
For any police vehicles or ambulance?
Only our ambulance is all I can remember, yes.
So you got authorisation to move to Salisbury District Hospital, and you said that Richard Tilsley, who you'd referred to before, had authorised us to move. Salisbury would be accepting the patient, and the Heart were going to meet us at the hospital. So when you departed, was that the information you had? That
was what we understood, yes. And the thought about the hazardous area response team is that they would meet us at the hospital with a view that they provide a decontamination capability for the patient and indeed us.
And you say that Lee Martin called the hospital en route to give them a clinical update. Did that happen then? Yeah, so that's a standard procedure using the red phone that we discussed earlier for any patient that we have a critical concern about. So we use an acronym called ATMIST, which is age, time, mechanism or symptoms, and some of the measured physiology, some of the drugs we'd given, and then that gives them a succinct update and allows them to make space in the resuscitation room and then prepare the necessary teams, and we hoped in this case it would be an intensive care team to come and care. So the hospital had a pre-alert from you, but did you receive an update mid-journey? Correct, we did. And tell us about that, please. So I remember on the journey, again on the open speech radio channel, to say that this was now not thought to be nerve agent. This was being scaled back. Obviously, we were to continue. The patient was still unwell, but I'm sure I've stated in here, haven't I? Yes, page 4, 10 minutes at the end. Journey. Stand down as the patient was being treated for drugs earlier, and the female who'd come into hospital that day was being treated in a similar way. So from whom was this update coming? I know you said the open channel, but do you remember who it was? I don't know who that's from. I imagine that's a command decision. But it's from within the ambulance service? Yes, yeah. But I would assume that's come from a discussion from the hospital as well. Had you been told when you were at the property or in the ambulance that Dawn Sturgess was a suspected case of nerve agent poisoning, or had your assessment been based on Charlie's presentation? Sorry, repeat that, had I? Sorry, had you been told while you were at the property or in the ambulance that Dawn Sturgess was a suspected case of nerve agent poisoning? I don't recall that myself, but Mr. Martin made that phone call and discussed with the hospital, and certainly the response to, or the way that they described the response, Ms. Sturgess' response to a particular course of treatment was similar to that of the Salisbury incident, which reinforced us to continue with the decisions that we made to treat Mr. Rowley for nerve agent poisoning. But as I say, I was not making that phone call, but Mr. Martin can help you with that. So what was your response to the advice you received partway through the journey to the hospital that the incident was being scaled back to drugs only without a heart response?
Particularly concerned, frustrated, clearly. But it didn't change the way I was, or we were still very certain that this patient needed to have the same treatment as we were giving. At this point, he was quite stable, and we weren't giving additional drugs en route to hospital. But we were quite firm in our minds to advocate for this gentleman, that we felt that this was the cause, and that our treatment and working diagnosis was going to continue to be the same.
So it didn't change your actions which were going to the hospital?
No, not at all.
If I could deal now with arrival at the hospital, and if we could have up on screen, please, the part of your witness statement that deals with this. It's INQ 005542, page 5, paragraph 2. And we can see there, and I'll just read it out. On arrival, we were expecting to be met by a team of people. Although they had stood down the major incident, we still had a critical patient on board, but we were met by only one nurse in the bay, along with security guards also. There was also a consultant there. I knew him as Essam, although I'm unsure of the spelling of his name, and a doctor at the hospital, Paul Russell. Russell told me to take my mask off. He seemed quite happy that this was drugs and didn't seem particularly concerned. However, I did not deem this appropriate, so I kept all my protective clothing on.
So you're met, in fact, by a nurse, a consultant, and Dr. Russell. Is that right?
When we arrived in the room, it was just a nurse that was in that resuscitation bay, and these individuals arrived later as we were transferring the patient.
I follow. Cool.
So what did you say to Dr. Russell, if anything?
So to give context, this was post the handover of the patient care. I remember distinctly Mr. Russell saying to me that this was categorically, I remember that phrase, being drugs, and to take you don't need that PPE on. Clearly at that point I'd been frightened for the 2-hour duration with the patient, and my response was that it is personal protective equipment, and I elected not to follow that advice, and I maintained that or kept that level of PPE on whilst being in the proximity of the patient in that room.
Did you explain to Dr. Russell your reasons for suspecting nerve agent poisoning?
That was all detailed in the handover, very much so, yes.
Did that handover include passing over the clinical record at that time?
Very much so, yes.
And did Dr. Russell say anything else other than
I don't
telling you
recall that. No.
And did you tell Dr. Russell that you'd administered atropine at the scene?
Yes, yes.
You told him verbally as well as passing the
Part of the team that had eventually arrived for the handover, yes. Yeah.
You've said that you were thinking about the Salisbury incident from when you arrived. Had you been thinking about the Salisbury incident when attending any other incidents since March? Or was
Very much so, both professionally, but living and breathing, and obviously, unfortunately, clearly not as much as the family of Miss Sturgess and everyone involved, but it was big locally, and it was certainly in my mind. And I remember quite openly multiple patients that we were going to in between the Salisbury and Amesbury incidents were actually asking us if we'd been involved. Clearly that was not something we could divulge, and I had 2 or 3 patients separately say that if we were contaminated, they didn't want us treating them. And that was it was a scary time.
When you were thinking about that at 9 Muggleton Road, did your thinking extend to this could be inadvertent exposure to the Novichok from Salisbury, or it could be targeted, or did you have no thoughts of the specifics?
I remember Mr. Martin and I having a conversation around, this is what we felt to be quite a big thing to declare as such, and I remember sort of working through hypothesis, if you like, of is this a rational decision? Are we really making, this is a big thing to declare, and are we being totally rational? And I remember a discussion between him and I around, is this a discarded thing, or has someone been asked to perform this act, and that's the collateral damage.
So you did actually discuss that
I
at
remember
the scene?
discussing that distinctly with Mr. Martin, yes.
And you indicate in your statement, I think, that you disposed of your PPE in clinical waste at the hospital before you left. And did you take your uniform off when you got home after your shift? And had you already washed and dried it by the time you received calls from Public Health England, Occupational Health and your management telling you to double bag it on the Wednesday the 4th of July? We've heard other evidence this week that that was the date by which Novichok had been identified and counter-terrorism took over the investigation. So that concludes my questioning of Mr. Channon, but I would ask for permission to adduce the witness statements of two witnesses referred to in the evidence of Mr. Channon. That's Lee Martin, his crewmate, whose statement is INQ 005143, and Ian Parsons, the lead paramedic at the scene, which is INQ 004992.
Yes.
Thank you. There'll be some more questions for you. Thank you very much.
Thank you.
Just wait there a moment, Mr. Channon, would you?
Good morning. My name is Michael Mansfield. I'm representing the family of Dawn Sturgess. And I'm going to just a few follow-up questions to the sequence. I'll try and keep the same sequence so it's easy. I want to go back, if I may, therefore, to very near the beginning. Between the events in Salisbury and that attack on the Scripples and the events in Amesbury, as someone who'd been involved, just want to ask you this. Were there any...
I'm sorry, as someone who'd been involved in what?
Well, he was involved, if you kindly let me finish the development, it is in fact involved in the Scripple attack in the sense of being on duty at that time. Yes, you're nodding. And there were others who were obviously on duty at that time, is that right?
Yes, so I didn't
Yes.
attend the patient, but yes, worked locally when it happened. So.
Right.
Now, the point of the question is this, if I'm just turning back. During that interval of time, were there any gatherings, meetings, seminars, in which people like yourself who had been involved in the incident in the sense of treating people or being involved in support services, was there any meeting between yourselves and people from Porton Down as well, scientists coming in, and others, other emergency services, whereby the experiences that you had was passed on to other medics, police officers, and so on?
That's not something that I took part in, no.
No. Are you aware that any took place?
I wasn't aware, no.
Now, you indicated also near the beginning of your evidence that you indicated there was a recognition of the signs and symptoms, a distinction sometimes made, but without a difference perhaps, but signs and symptoms of organophosphate poisoning, and equally the signs and symptoms of opiate poisoning, an overdose. Yeah, you're nodding, I'm sorry. I have
Sorry, yes, that's correct. Yes.
Sorry, it's just that it has to be recorded, I'm sorry. So, but the additional question I want to ask is, you were alive to the possibility, that these could be confused.
Correct.
Right. Now, what I want to ask is whether before Amesbury there had been any documentation or training which dealt with how you might deal practically with the risk that you might confuse. In other words, were practical steps being suggested in training or documentation or not?
So other than, as I alluded to, the reissuing of standard guidance, there was no specific guidance that I recall, or training that I recall, saying that, or training us to recognise the difference between the two specifically, no.
I mean, as far as you're concerned, how would you, we know what you did in this particular case, one assumes that in a way it is reflected, but what steps, and this is for the future, have to be taken in order to, as it were, eliminate the risk as far as is humanly possible before you ever get to a hospital situation?
Could you rephrase that? So eliminate the risk of confusion?
Yeah, the risk of confusion, yeah.
So I think there's always a clinical judgment, and we can prepare for treatment of both. Clearly, opioid overdoses or opiate overdoses are common, and treatment for such is therefore common. I think the treatment of nerve agent poisoning, and this is a professional opinion, is clearly rare and unprecedented in the UK. So preparation for such, hopefully we can exercise and learn from this. But without the context of knowing the substance is present, I feel that it's quite difficult to pinpoint that it is actually nerve agent poisoning at the time. And I think we were fortunate at the Amesbury incident, sadly, but we'd had lots of recent reminders, and therefore that fed into our suspicions. Had the Salisbury incidents not taken place, I think we would have recognised that the behaviour was particularly abnormal, but I'm not confident that would have been an immediate recognition that it was organophosphate poisoning.
Now, just continuing with this theme, if I may, if you're in a situation whereby it could be organophosphate, or it could be Novichok, obviously now you know about it, or it could be opiate poisoning or overdose, is there a maxim like this, that it's best if it could be an organophosphate or Novichok, you must err, as it were, on the safe side, as it were, and take precautions in case it is?
That sounds very reasonable, yes.
In other words, even if a police officer thinks differently, if the possibility you say is that it is Novichok or something like that, then you take the necessary precautions.
Very much so, yes.
Now, after Amesbury, I've got a few more questions about Amesbury in a moment, but after Amesbury, the question I was asking earlier, have there been, I'm going to call them gatherings, whether they call them gathering seminars or whatever, in which you and others who were actually practically involved, and you just gave the example, without being to Salisbury, you might not have been able to give the service that you did. So after Amesbury, has there been a collation of materials and people to pass on the experience you've given?
There hasn't been, and my rationale and thought process is probably that's due to patient confidentiality and investigations from the police. That's my thought process as to why we haven't been able to share information.
Right. Now, can I just go back to Amesbury itself and that particular day? I'm sorry to anonymise it in this way, but there comes a point, and I'm not asking for a precise time, at which you're as firm as you can be in your own approach that this is similar to Salisbury, and would the word almost certainly fit? It almost certainly was Novichok or something of that kind.
Yes, yes.
Now, Had you arrived at that opinion yourself, as well as the others who were with you? You all agreed the same thing?
Between myself and my colleague, Mr. Martin, in the same room, that was our joint opinion, yes.
It's your joint thinking. So I can only ask you about your memory, not other people's. So in relation to that joint opinion you'd arrived at, firstly, did you yourself, or through someone else, communicate to the outside world, I'll deal with the outside world in a moment, communicate to the outside world that this was the joint firm opinion of the team?
Yes, and that's reflected in the call logs you've seen.
Yes, I'm not going. You've been through the call log. I'm not going through that. So it was communicated. So can we include in that range of people to whom it was communicated outside the hospital itself?
Yes.
Now, are you able to help us as to the point in time at which you were able to, or somebody from the team was able to tell the hospital what your joint opinion was? I mean, was it one of the Lee Martin, because we've only got his statement, one of the Lee Martin calls or something, some other communication? The open radio? What?
So Lee Martin, when he made that phone call, I can't recall the exact details, but obviously that will be in his statement. But I should imagine that was what he'd said to the hospital. But the confirmation that that was our working diagnosis was through our command function, through Mr. Parsons and indeed Mr. Tilsley, who then, on behalf of the ambulance service and us, would have communicated that officially to the hospital.
Right, right. So it's one of at least two routes.
Two routes,
either
correct.
Martin or your command structure. So that's the hospital. Now, in terms of, sorry, excuse my throat, the arrival of police, you made it very clear on their arrival, I say you as a team, made it very clear on their arrival that that was your view.
Correct, very clear, yes.
Now, I'm not asking for the document unless you can't remember, but would it be fair to summarize your reaction to their approach, up the stairs, no protective clothing, cordon breached and so on? Would you have you described their approach, the police approach, towards you as being dismissive?
Correct, yes.
Did that shock you?
Very much so, yes.
And after these events, after Amesbury, has there been any review of how this was handled by the police, as far as you're aware?
Not that I've been involved in, no.
Not that you've been involved in. Now, in relation to that, have you yourself been offered any kind of apology in relation to this?
So we've had discussions with Deputy Chief Inspector Mills over the last few days, and that's been, yes, we have been.
All right, yes, I just needed to know. So it's happened in the context of this inquiry. I mean, you've been here when it happened.
Correct.
Yes, all right. And in terms of their entry into the premises and then into the ambulance and so on, that whole sequence of behaviour, was there anything at the time you felt you could do about it? In other words, to prevent the dangers of people with no protective clothing coming in the premises, no protective clothing getting into the ambulance and so on?
I was firm in my communication and used my, and what I can rely on is my clinical knowledge, and advised them that my thought was that they should don PPE. Now, I would suggest that if a firefighter or a police officer had said the same to me, that I would follow that advice, yes.
I mean, retrospectively, do you think there was any more you could do to prevent the police doing what they were doing?
I didn't feel that that was within my power, no.
No. Whose power was it within?
I would suggest that would then go back down to what we were saying was the GESIP huddle and the joint principles of communication amongst the emergency services. Clearly, I can explain a risk to people, but I couldn't force someone to apply their own personal protective equipment, as you understand, sir.
Have there been discussions, which include you? I'm not talking about discussions you're not part of, obviously. Have there been discussions about how this problem should be resolved in future, as far as you're concerned, so you don't have a situation in which one of the emergency services, as opposed to the other two, disagree about how to deal with the situation?
Not discussions I've been involved in, but certainly aware of, and since the incident I was then an operational commander and attended a lot of GESIP training, and certainly in the last 6 years I've seen a better joint working amongst all emergency services, not specifically as a result of my involvement in this case, but certainly those principles are very much more embedded than perhaps they were 6 years ago, so yes.
Yes, just pause one moment. Thank you. Yes, so that's all I had to ask.
Thank you for your help, Mr. Mansfield. It's very useful. Mr. Channon, is there anything else, Ms. Whitelaw? No. Mr. Channon, that's all that anybody has for you. Thank you for your help. You're free to go, though, of course, you can stay if you want to.
Thank you, sir.
Right.
Slightly early, sir, I'm afraid, but not...
Don't apologise. It's a good thing. And in any event, nobody can ever predict accurately, precisely how timings are going to work. It's 22 or near enough, 20 to 1. Quarter to 2? Quarter to 2.
Thank you very much.